Hi everyone, thanks for tuning in. Welcome to our Facebook Live on Parathyroid Disease. My name is Dave Schneider. I'm an endocrine surgeon at the University of Wisconsin in Madison. And I'm so excited to talk about parathyroid disease because July is actually Parathyroid Awareness Month, so this is well timed. The parathyroids are four tiny little glands that sit low in the neck near where your thyroid is. So we're talking about this level in the neck. They control the calcium in our blood and in our bones, so they're super important. Sometimes one or more of these tiny little glands becomes overactive, and when they're overactive, they make too much of their hormone, which is the parathyroid hormone, or PTH for short. And what that does is it raises the amount of calcium in our blood. The problem with that is that it's stealing the calcium out of our bones to put more in our blood, and whatever's in our blood we end up getting rid of through the urine. The high calcium in the blood can also lead to osteoporosis, kidney stones, and then a whole set of symptoms, everything from aches and pains, headaches, joint pain. It can lead to abdominal pain and constipation, a ton of symptoms that generally make people feel lousy. And so if you have a parathyroid problem, often patients go unrecognized or undiagnosed for a long period of time while these other symptoms get addressed before the underlying parathyroid problem is discovered. The good news is that when you get this problem treated, people generally feel a whole lot better and their quality of life dramatically improves. So why don't we go from there into taking some of your questions?
Okay, so the first question is, how do you know if you have parathyroid disease?
Parathyroid problems are diagnosed by blood tests or biochemical tests. And that's the key, and that's one of the things that we're trying to raise awareness about for Parathyroid Awareness Month, is that the best test is to first get your calcium checked. If the calcium's high, then the next step would be to get your parathyroid hormone or your PTH checked. Now, in some cases, there's a bunch of other testing that may need to be done if the diagnosis isn't clear from those two initial tests. But the bottom line is that a calcium and a PTH are needed to make the diagnosis, and that's really how we make the diagnosis. It's not based on imaging or any other tests that you can do. Those are mainly the two main tests that we do in order to make the diagnosis.
So how can I find a good parathyroid surgeon?
That's a great question. Well, of course, at the University of Wisconsin, there are 4 of us endocrine surgeons, but if you're not in this part of the country, the AAES, which is our professional society, the American Association of Endocrine Surgeons, is a great website where you could find a parathyroid surgeon near you or an endocrine surgeon near you, and that is at endocrinesurgery.org. The AAES also has a great patient education website in case we don't get to your question or you have more questions after today. And that website is endocrinediseases.org.
If the parathyroid regulates calcium in the body, could a sudden onset of kidney stones, the kind of stones from excess calcium, be a symptom?
Yes, absolutely. And kidney stones are one of the main symptoms that should trigger an evaluation of a parathyroid problem. So if you remember what I was saying before, the high calcium that's in the blood ends up in your urine, and in some patients the high calcium in the urine forms a stone. And so if you have kidney stones, especially calcium-containing kidney stones, then for sure that could be a symptom of parathyroid disease, and you should definitely get your calcium and your parathyroid hormone checked.
My parathyroid hormone level is normal, but my calcium is over 11. Could I still have a parathyroid problem if my PTH is within the normal range?
Yes, that's another great question. So the normal ranges are a good guide, but the real diagnosis is made by the relationship between those two numbers. So normally, if your calcium is high, your PTH should be really low, and vice versa. So those two numbers normally should work in opposite. And so what I try to do is look at both of those numbers together and determine whether or not the relationship between those two numbers is normal or not. The absolute value of the number or the absolute normal range doesn't mean a whole lot to me for two reasons. One is the relationship may be abnormal even if the numbers are technically in the normal range. And two is there is a type of hyperparathyroidism called normal calcemic hyperparathyroidism, where the calcium is actually normal, but the PTH is too high. And so if you're in that scenario, or you think that that may be the case, you really need to see an expert, either an endocrinologist or an endocrine surgeon like myself, to help you sort that out. There are a number of other causes for elevated PTH, including kidney disease, bone disease, vitamin D deficiency, malabsorption from your GI tract. So it really depends on the individual, and this is a scenario where you really need an expert to help you sort that out.
How common is this disease? My doctor told me it was too rare for me to have it.
Yes, that's a very common misconception. So if you read the textbooks, people say that this disease is quite rare, probably 1% or less of all the population. But there have been a number of studies now from very large medical systems such as the Kaiser system or the Cleveland Clinic system, where we've discovered that parathyroid disease is a whole lot more common than what we think it is. And that's because this disease is incredibly underdiagnosed. We here at the University of Wisconsin have come up with a automated way of detecting it using the electronic medical record system and using artificial intelligence or computers in order to automatically flag patient records that have a high calcium or have abnormal calcium in PTH, in order to make sure that we capture and diagnose these patients a lot better. I think that if we were really honest about it, the true incidence is a lot higher than just 1%. It's probably somewhere between 4 and 8%, but we don't know the true number because, as I was saying, unfortunately, this disease is incredibly underdiagnosed.
My calcium and PTH are both high, and my doctor has told me it's because of vitamin D deficiency. Should I take vitamin D supplements? And if so, what kind?
Another great question. So vitamin D deficiency is a common reason to have an elevated parathyroid hormone. But usually what happens when you have vitamin D deficiency is that your calcium is low and not high. So if your calcium is very high, then and your parathyroid hormone is high, then I would think that for sure you probably have primary hyperparathyroidism. And correcting your vitamin D in that scenario could potentially be dangerous because it could make your calcium go even higher. So in that case, I would say it sounds like you probably have hyperparathyroidism and you need to get that addressed and fixed. Vitamin D deficiency often goes along with hyperparathyroidism because the high parathyroid levels can help degrade your vitamin D levels, and it's very hard to maintain a normal vitamin D level when your parathyroid hormone is so high. But I would get your parathyroid problem addressed first, and you may need to have your vitamin D fixed or repleted after you get your parathyroid problem fixed first. So that's a great question. It's a common misconception and a point of confusion even among healthcare providers.
Is there any association with low levels of serum anion gap and primary hyperparathyroid disease?
That's a good question. That is true, but not everyone with hyperparathyroidism has an abnormality in their anion gap. It's associated anywhere from 20 to 40% of cases, so that alone is not a diagnostic in and of itself. as I said, the main way to make this diagnosis is with your calcium and your parathyroid hormone levels and the relationship between those two numbers.
Can suppressed parathyroids, autoimmune, ever turn back on?
That's an interesting question. So when you have one overactive parathyroid gland, it can suppress the others, and often it takes a few days to even a week before the other glands can wake up after we remove the overactive or adenoma. I'm not familiar with an autoimmune disease that specifically targets the parathyroid glands, but in general, yes, parathyroid glands that are suppressed can wake up and do wake up afterwards.
So Amy says, I have a high PTH, normal calcium, and normal vitamin D levels. I'm having imaging this next week, but if the imaging comes back negative for tumors, what might my next step be?
That's a great question. So first of all, like I said before, the fact that one number, either the calcium or the PTH, is normal doesn't mean that you don't have the disease. 80% of people will have just one gland, or we call that a single adenoma, that's the problem. But 20% of people will have more than one gland causing the problem. Imaging is really all geared towards finding what most people have, which is just one gland that's the problem. So if the imaging is negative, that does not mean that you don't have a parathyroid problem, and it doesn't mean that the problem can't be fixed with surgery. It just means that either that imaging test couldn't find the single gland causing the problem, or maybe more likely in this case, that you have more than one gland, and in that case, any imaging test may not ever show it, because all those tests are kind of geared towards finding a single gland, and you may have more than one gland. An expert parathyroid surgeon or an endocrinologist can help you sort that out, can help you interpret those tests, and even decide which types of imaging tests are even appropriate.
What drug options are on the horizon beyond Para?
Okay, so Netpara is actually for treating the opposite problem. So patients that have a low parathyroid hormone or don't have enough parathyroid tissue in their body. This could be a complication from other neck surgery or from thyroid surgery, and the idea is to replace their parathyroid hormone levels if they can't make enough on their own. In terms of treating overactive parathyroid problem or overactive parathyroid glands, really the only treatment that we have is surgery. There are other drugs out there like Sensipar that help make your lab values better, but they will not strengthen your bones back up, and they won't treat the underlying problem. So as of today, the only and best treatment for a parathyroid problem is really just to get the overactive gland or glands removed, and that means a small surgery.
Does it matter what kind of calcium supplements a patient takes?
That's a good question. So there are a ton of calcium supplements out there. Now, if you have a parathyroid problem, we don't recommend that you take calcium supplements until you get that parathyroid problem fixed, because taking extra calcium can raise your calcium levels even higher, and that can be dangerous depending on how high your calcium is and how high you could potentially go. If your calcium's too high, it can really lead to dehydration and kidney problems, and so you really want to avoid that. After surgery, we really emphasize taking a calcium supplement in order to strengthen your bones back up, and that includes also correcting any vitamin D deficiency that you may have that was actually caused by the parathyroid problem in the first place. There are a number of different preparations out there. Calcium carbonate is something that we use often in the initial period. Calcium carbonate is just Tums, and Tums are really easy to take because you can just chew it up, it gets absorbed right away. But calcium carbonate, even though it has a lot of calcium per gram, it is really difficult to be on long term because it can cause bloating and constipation, and so often Longer term, we recommend that patients go on a different supplement, something like calcium citrate, because it's a little bit easier tolerated, better on the GI system, easier to take. Overall, after you get your parathyroid problem fixed, we don't care so much about what specific preparation you're taking, as long as you're getting enough calcium per day, and typically that's about 1,200 milligrams per day. And we also want you to take enough vitamin D per day, and that is somewhat guided by your specific vitamin D level. But a great question. I know there's a ton of supplements out there. I would say if you've had a parathyroid surgery and you're wondering what to take, we kind of take a personalized or specific case-by-case basis for each patient, but you should talk with your provider or your surgeon to figure out what is right for you.
Should a PTH be drawn if a patient has elevated calcium?
Absolutely, a PTH should be drawn if a patient has an elevated calcium. For patients with a high calcium, hyperparathyroidism is the most common cause, and as I was saying in the beginning, if you have a high calcium, the next step should be to get your PTH drawn. So yes, absolutely, you should get a PTH drawn.
Is there a time frame to monitor / recheck PTH and calcium before referral for possible parathyroid disease?
That's a very good question. So patients that have hyperparathyroidism, the diagnosis is made by lab values like we've been talking about. And often patients will be told that they should just recheck their levels. As we said before, rechecking your levels isn't really treating it. So most patients that I see that have this disease, I end up recommending that they have it treated, and that means getting surgery or getting a parathyroidectomy, because it's really the only way to fix the underlying problem. I think the urgency of that is even greater if you have osteoporosis, if you have kidney stones, if your calcium is very high. There are guidelines for treating hyperparathyroidism and indications for who should wait until they have those things. But again, I think at UW Health, we really feel like if you have this disease, it makes sense to get it treated no matter what those things are, because we want to prevent any future bone loss, prevent any problems from happening down the line. And so we recommend that if you have the disease, that you do go ahead and get a parathyroidectomy. In our hands, we know that it's safe, we know that it's super effective, and most people have a better quality of life. And so in general, I would say that if you have the disease, that you should really think about having a parathyroidectomy and talk it over with your providers.
Teresa says, I am 6 months post-op and my parathyroid level is high again. Does this mean I have another tumor?
Yes, that's an interesting question. So after surgery, the 6-month mark is where we really define whether or not patients are truly cured or not. I would have to see the exact calcium and parathyroid hormone levels, and we would also want to kind of compare it to your preoperative levels in order to definitively say whether or not you have another tumor or you're not cured or it's another one has causing a problem now. A lot of factors can go into having a normal calcium and an elevated PTH. It could be vitamin D deficiency, it could be malabsorption, it could be bone disease. And so I guess right now I don't have enough information. It could mean that you do have a recurrence or another tumor that's causing a problem. So if you're in that situation, I would say definitely talk it over with your surgeon and your endocrinologist. It could mean that you have another tumor, but it also could be a number of other things. And so I guess I would need a little more information in order to say for sure.
Many patients require reoperation, often due to the lack of localization of diseased gland. To provide more comprehensive care and avoid reoperation, should there be a greater role for use of selective venous sampling and/or 4D CT?
Okay, so that's a little bit of a complicated question because the question involves both imaging and reoperative parathyroid surgery. So let's first talk a little bit about the imaging question. As I said before, 80% of people have a single adenoma, but 20% of people have more than one gland that's causing the problem. Most of the imaging tests that we have are geared towards finding a single adenoma. What I try to do is look at a patient's lab values and help kind of determine whether I think they're in that 80% group or in that 20% group. If I do think that they're in that 80% group where they have just one single adenoma or single gland that's the problem, then I think it does make sense to get an imaging test, because we can offer you a minimally invasive approach or a focused surgery in order to remove just that single gland that's the problem. It's also important in that situation to make sure that that is truly a single gland, and so we use intraoperative PTH testing to do that. Now, if you're in the other group where it's likely that you have more than one gland, then I don't think it makes a whole lot of sense to do a lot of extensive imaging tests that are focused on finding just a single gland, which may not be the case at all. It may mean that you have more than one gland. And so we really take a personalized approach to this, where we first look at your labs and decide if you truly probably have a single gland or if it's likely that you have more than one gland. If it's likely that you have more than one gland, then we can absolutely still fix that problem. It just means that during your surgery, your surgeon probably needs to look at and carefully examine all 4 glands. And so it doesn't make a whole lot of sense to go through the cost, the time, the expense, the radiation exposure to get a lot of fancy imaging tests when they're looking for something that's not really there to begin with. The question also involved reoperative parathyroid surgery. And that's a little bit different, but again, I would approach it the same way, in that I would look back through your original operation, what happened, what glands were visualized, what did the intraoperative PTH levels do, where your labs are now, and again, figure out, do I think that this was a single gland all along? Or do you really need a reoperation because you were never cured and you likely have more than one gland, and that was the case all along? If we do think that you have a single gland, then I think it does make sense to get imaging, and often in reoperative setting, it's required or recommended to get multiple imaging tests to really pinpoint where it is so that we can do safe surgery. We have the full gamut of imaging tests, and each one has its advantages and disadvantages, and we have different reasons for getting them. So things like PTH sampling or PTH localization of parathyroids, that's a very specific test. We would only use it in very specific circumstances. Same with 4-dimensional CT scanning. That test is very useful, it's very sensitive. And we may recommend that, especially in the reoperative setting. But we try to tailor everything to the person and exactly what's going on with them. And again, I think in a first-time operation, it really comes down to, do we really think you have a single gland or more than one gland?
Lynn says, I had surgery a month ago with one parathyroid gland removed. I've had 2 episodes of kidney stones since then. When will I be free of these stones?
Yeah, it's frustrating if you've had kidney stones and then you have surgery and you still have the kidney stones. So I will say that not all kidney stones may truly be due to parathyroid problem, although if they're calcium-containing stones, then I would say it's quite possible that they are, and it's very likely that they are. Now, after parathyroidectomy, if you have kidney stones, and they are calcium-containing stones, and they are due to parathyroid disease, this should, if you're truly cured of your parathyroid problem, it should prevent any new stones from forming. Stones that were already existing, that were already in the kidney or in the collecting ducts, we can't get rid of those, and so those may still be causing a problem. So I guess I would say, talk with your surgeon and find out if those stones were there before you even had surgery. And then I would say it's probably important to confirm that your parathyroid surgery was successful, and that would be, again, getting a calcium and a PTH checked. So I guess it's a complicated question, but I think the first step would be talk with your surgeon, make sure that your calcium level is back down to normal, that everything looks good on that end. And it may be that you had some stones that were still in your kidney from before, and hopefully once you pass those, then you won't get any new stones from forming.
I was told I need parathyroid surgery. Should I have all 4 parathyroids removed or biopsied?
That's probably a very controversial question. I can tell you what we will do here at UW, and I think it goes back to what I was saying earlier regarding imaging. So remember, 80% of people have just a single gland or a single adenoma. If you fall into that category, then you don't necessarily need to have all 4 glands looked at, examined, and biopsied. If it's likely that you fall into the category where you have more than one gland, we call that multi-gland disease, then yes, absolutely, you should have all 4 glands examined. The downside to saying that we should examine all 4 glands in absolutely everybody is that most people will just have one single gland, and one risk of parathyroid surgery if we examine all 4 glands is that we could potentially damage all 4 glands, and then you would be in the opposite category or the opposite problem where your calcium is too low. And so we really don't want to put patients into that scenario because in some ways that's very hard to treat, and as we were saying before, there's not a lot of medications or ways to treat that. So we take a very personalized approach. The first question is, are you likely to have just a single gland? If you are, then I would say imaging and a focused surgery is probably the right thing to do for you. We also use intraoperative PTH measurement during the surgery, and we really scrutinize those numbers to make sure that indeed you do have just a single gland and that taking out just that one gland will be curative. If you have more than one gland, then absolutely you should have all 4 glands examined. The key to that is that you really need an experienced surgeon who knows exactly where to find the parathyroid glands, is good at handling them, because we don't want to put you in that opposite category or the opposite problem where your calcium ends up too low because all 4 glands were damaged or ruined. So this is a scenario where you really need an expert parathyroid surgeon.
Gretchen wants to know, is parathyroid disease more of a female disorder?
Like a lot of endocrine problems, yes, parathyroid disease tends to affect females more than men. It's usually about a ratio of 3-to-1. So unfortunately, yes, it does tend to affect females more than males, but I've had a number of male patients that we've successfully treated as well. I think it tends to go even more unrecognized and undiagnosed in male patients because it's just less common in males.
I have a parathyroid problem and I don't want to have surgery. Are there other treatment options?
Great question. So the most definitive way, the only way to really treat the problem and get rid of it once and for all is surgery. I guess I would try to find out from the patient then why you don't want to have surgery. Often, especially in experienced hands, a parathyroid surgery is much less big of a surgery than you may be thinking that it's going to be. We do it as an outpatient procedure where patients go home the same day. Often they're feeling great and back to all of their usual activities within a week after that surgery. And in a lot of cases, they feel even better because now they have their parathyroid problem fixed and they're feeling great, they're feeling younger, their bones and joints all feel better, and their quality of life dramatically improves. So in short, surgery is the only way to really fix this problem. And if you're scared of surgery or unsure about it, you should really talk to an experienced parathyroid surgeon because it may really be the best thing that you ever do for your health, and it may be much less of a big deal than you think it's going to be.
Karen says, I have both thyroid and parathyroid issues. Is that unusual?
You know, it's probably a little more rare, but a lot of patients have thyroid problems because thyroid problems are incredibly common. One thing we do here at UW Health is that we make sure that all of our thyroid patients that we check their calcium and their parathyroid levels before we do any surgery on them, because if they do have a parathyroid problem, that can be fixed at the same time. Likewise, if you have a parathyroid problem, we also look at your thyroid to make sure you don't have any thyroid problems, because again, we can fix that at the same time. So I would say that it's not that uncommon. If you have a surgeon that's experienced in both, then you should be able to get them both treated at the same time, and in a minimally invasive way. So great question, and it's something that we make sure to look out for in all of our patients.
Okay, and our final question is, if I have my parathyroids removed, do I need to take a hormone supplement afterwards? Great
question. So as we were saying before, there really isn't a great way to treat parathyroid hormone levels that are too low. Now, if you've had surgery by an experienced surgeon, then hopefully that won't be your problem. And hopefully that means then that you have enough parathyroid tissue remaining in your body to continue to regulate the calcium in your blood. So what we recommend at UW Health is that after your parathyroid problem, the only thing you really need to take is a calcium and a vitamin D supplement. And the reason for that is to replete your vitamin D and to strengthen your bones back up after surgery, because the parathyroid problem will weaken your bones over time. And so once we fix it, we really want to strengthen your bones back up. And so we put all of our patients back on a calcium supplement after surgery. There really isn't any hormone that you need to take, especially if you've had surgery where you have enough parathyroid tissue remaining in your body. But great question. All right, well, thanks everyone for tuning in. If you are in the area and you think you may have a parathyroid problem and you want to come see one of us at UW Health, we're happy to see you. You can call our clinic at 608-242-2888. Again, that's 608-242-2888. Thanks everyone for tuning in.